I want to express my gratefulness to the Neurocritical Care Society, and especially to Olivia Gosseris, to invite me as a speaker to this online conference, the World Coma Day. My name is Calixto Machado, full professor and researcher of neurology and clinical neurophysiology from the Institute of Neurology and Neurosurgery, Havana, Cuba. Brain death concept has been progressively accepted since the late 50s. Nonetheless, contentious brain death cases have recently raised new controversies about brain death diagnosis. This is the case of Yahya McMash, widely covered by the US and international press. 13 years old, Yahya McMash underwent pharyngeal surgery for obstructive sleep apnea at the Auckland Children's Hospital on December 9, 2013. Later that evening, she suffered a massive hemorrhage inside her respiratory pathways, leading to a cardiorespiratory arrest. Yahya was officially declared brain dead on December 12, 2013. Her family did not accept this diagnosis and began a controversial legal dispute against the hospital. Nonetheless, the family and the hospital reached an unusual agreement to release her body to her mother with a ventilator and intravenous fluids. She was later discharged from the hospital and was moved to New Jersey, where patients' relatives can accept either a cardiorespiratory or a neurological view of death. In September 2014, I was called as an expert and flew to New Jersey. Yahya was studied at the Rogers Hospital in New Jersey. As Yahya's parents did not permit us to perform an apnea test, I suggested using ancillary tests according to the American Academy of Neurology guidelines for brain death diagnosis. I was really shocked when I saw in her MRI preservation of intracranial structures despite enormous abnormality. It was documented 9 months after her initial cardiac arrest. Her MRI showed a methylation in the posterior region of the pons. MRI tractography placed over MRI views showed tracks connecting the brainstem and thalamic cortex and also interconnecting cortical areas. This is a 3D reconstruction of intracranial structure of both hemispheres and also the left hemisphere. You can see the preservation of intracranial structures. In brain death, a complete arrest of cerebral blood flow should be expected. Nonetheless, MRI from Yahya shows the supraclinoid portion of the internal carotid arteries. You can see it with the red rows, indicating preservation of intracranial cerebral blood flow. Her EEG showed an background activity over 2 microvolts, okay, with prevalence of diffuse theta activity, but the activity was there. QEEG spectrum also, in two derivations, FP2 and FZ, showed an incipient but observable peak in the alpha band, and in O1, there was a visible delta peak present. We also assessed her autonomic nervous system using the heart rate variability methodology. The power spectral density for the whole heart rate variability spectrum showed discrete spectral frequency within the very low frequency band, the middle frequency, high frequency, and very high frequency bands. That means that there was an autonomic function remaining in Yahya. A very important finding was her autonomic response when her mother talked to her. You can see in this slide a thick vertical line indicates the beginning of the mother talk stimulus compared with the basal record, indicating an evident autonomic response when her mother talked to her. Hence, it was possible to find a manifest autonomic reactivity to the mother voice stimulus. This result might be related to Dr. Schumann's video finding of Yahai responding to her mother command. The American Academy of Neurology and the California Guidelines for Brain Death Diagnosis affirm that an individual is pronounced dead by determining an irreversible cessation of all functions of the entire brain, including the brainstem. Did Yahai McMash fulfill these guidelines? I think no. Comparing Yahai with other disorders of consciousness, I can affirm that she was not in coma because she had a total absence of brainstem reflexes, partially preserving responsiveness. Yahai was not either in unresponsive wakefulness syndrome, the so-called PVS, because she was not in a wakeful state and showed partial responsiveness. She was not in a minimally conscious state because she did not preserve arousal and preserve awareness only partially. She could not be classified as a lock-in syndrome patient because lock-in syndrome patients are wakeful and aware and usually ventilate by their own. Summarizing the new state of disorder of consciousness, I would say that she had complete absence of brainstem reflexes, preservation of intracranial structures in the brainstem and in the cerebral hemisphere, preservation of EEG activity over 2 microwatt per division, preservation of all heart rate variability bands generated at the brainstem and other areas of the central nervous system, and very, very important, autonomic reactivity to the mother voice stimulus. In this slide, I compare arousal and awareness in the different disorders of consciousness and also in a normal subject. The new state, which a high match, did not preserve arousal and awareness was only preserved partially. In a search of a name, I propose responsive unawakefulness syndrome, RUS. I conclude that Jehovah's Match represented a new disorder of consciousness, none previously described, which I have termed responsive unawakefulness syndrome, RUS. This case does not contradict the brain death concept, but brings again the need to use ancillary tests in brain death determination and confirmation. In this slide, I give you all my contact details. I would love to begin a collaborative exchange with any colleague and institution from the world. Also, you can check and revise all my articles in my research site. Thank you very much.
Good morning, and thanks to Olivia Gosseria and Kerry Kim for inviting me to this important event, important for patients with prolonged disorder consciousness and their family, and also for clinicians involved in difficult management and care of such complex patients. I'm Anna Strano, a neurologist. I worked for about 25 years with the patients in prolonged disorder consciousness in neurorehabilitation unit, and now I work in a neurology hospital, in neurology unit in general hospital with the patients in acute phase. I'm also a co-chair with Daniel Conziella of this scientific panel on Coma and chronic disorder of consciousness of the European Academy of Neurology. Today I'm going to talk about what we know about clinical evolution, about factors that could impact the clinical outcome, and which markers and predictors we have for predict different recovery trajectory in such patients. Why to predict clinical evolution in prolonged disorder of consciousness? First of all, clinicians are routinely called upon to provide to patients' family reliable prognostic information for guiding decision-making and planning a more appropriate care pathway in terms of intensity and duration treatment. Moreover, it would be very important to identify patients with a high probability of recovery, also of late improvement, in order to allocate and optimize the always scarce economic and healthcare resources necessary for the management of such complex patients. Unfortunately, when we talk about prognosis of patients with the DOC, we talk in a climate of uncertainty, since now the relatively small number of studies on prognosis have been published, and most of them only in the last 10 years, and reported in the American Academy of Neurology guidelines. This climate of uncertainty is also confirmed in the two recent IBA international surveys that found that prognostic procedures markedly vary across countries, both in adult and in pediatric population with disorder of consciousness. To date, the clinical evolution of DOC has not been completely comprehended yet. In 1994, Multi-Society Task Force classified the vegetative state as permanent after 12 months post-injury in traumatic etiology and after 6 months in non-traumatic etiology. More recent observation of a possible, rare but not exceptional, late recovery of consciousness have called into question this classification that is closely tied to the reversibility of the clinical condition. And more recently, American Academy of Neurology guidelines recommended using the more appropriate term of prolonged disorder of consciousness when this clinical condition persists more than 28 days after injury, and the term chronic to identify patients after the 1994 classical time limits. In this view, the clinical evolution is especially influenced by the etiology. But also the clinical status impact the clinical evolution. This recent longitudinal IBIA study reported that the clinical evolution is worse in patients in vegetative state than in patients in MCS, since a high number of patients in vegetative state died or did not improve their clinical status at short, long, and very long-term outcome with respect to patients in minimally conscious state, likely due to low severity of brain damage and maybe better response to treatment in MCS patients. As you can see in this cohort of patients, we can have a late recovery of full consciousness in both patients. But what happens when the patients emerge from prolonged disorder of consciousness? The big database of the TBI model system identified 4 distinct prognostic subgroups of patients with different trajectories of recovery of self-care, mobility, and cognition. And some of them showed robust recovery over time, also over long-term time post-injury, until 10 years post-injury. But a late improvement of functional motor disability is still possible in anoxy patients, especially younger patients who might recover assisted walking after a very long time from the. However, most often functional improvement does not parallel recovery of consciousness. Patients with a different level of consciousness might show the same disability. Regarding survival, the mortality rate was high in the first year after brain injury than in the second year in both diagnostic groups, likely because of high clinical instability and higher risk to develop severe medical complications in the first year post-injury. Which factors can impact clinical evolutions? Of course, the clinical evolution might be influenced by the rehabilitation intervention. As you can see here in this large cohort of patients with prolonged disorder consciousness of traumatic etiology, the majority of them recovered consciousness and became partially or fully independent during inpatient rehabilitation. Also, the medical complications can negatively impact the clinical evolution, both mortality and then clinical improvement. But excluding these impacting factors, which markers and patients' characteristics may predict recovery of consciousness or functional disability? Prognostic markers have not been completely identified yet, unfortunately, since the majority of reliable and solid prognostic markers, such as absence of N20 cortical component recorded on somatosensory evoked potential, are collected in comatose state, and for this reason have been also included in the algorithm for prognostication of anoxic patients in the acute phase in these European guidelines. However, despite their clinical utility, these sample measures, neurophysiological measures, are rarely recorded in the intensive care unit, and clinicians of the rehabilitation setting lack of such prognostic information. Also, reliable prognostic markers for patients with late recovery or for patients in a minimally conscious state are lacking. In this recent longitudinal international multicenter study launched by IBA and funded by an European project, DOCMA project, we enrolled 147 patients with prolonged disorder of consciousness, 71 in vegetative state, and 76 classified as in minimally conscious state. We gathered clinical outcome until 24 months in 143 patients. At study entry, we collected information from medical history, etiology, time since injury, demographic information, patient's clinical condition, that is, level of consciousness measured by Coma Recovery Scale Revised, and the level of disability assessed by Disability Rating Scale. And also we recorded multimodal neurophysiological evaluation, easy to record at bedside, that is including EEG background activity, conventional EEG, N20 component on somatosensory, P300 on event-related potential. Cox regression analysis on the 135 patients whom all data were collected provided a significant final model in which only older age female sex were significantly associated with a higher risk of mortality until 24 months post-injury. But these predictors of mortality did not apply to the same extent in the two diagnostic groups. Indeed, in vegetative state, only older age, a lower level of responsiveness as measured by Coma Recovery Scale Revised total score, were significantly associated with higher mortality risk. Whereas MCS group, female sex and absence of alpha rhythm of an EEG on conventional EEG were significantly associated with a higher risk of mortality. About predictors of consciousness recovery, we found that lower age, as expected, shorter time post-injury, and higher Coma Recovery Scale Revised total score and presence of EEG eye-opening reactivity predict better outcome at 6 months post-injury. And the same markers, along with the male gender, may predict long-term recovery of consciousness at 20 and until at 24 months. Our data on the high prognostic value of EEG reactivity are in agreement with the data from this meta-analysis on neurophysiology in disorder of consciousness published in 2018. And also agree with this preliminary meta-analysis by Boris Kochubey that also included studies published after 2018, but Boris Kochubey emphasized that we should view these promising findings of a positive predictive value of EEG reactivity with caution due to high study heterogeneity and publication bias. That is, we only have only studies that favor positive results. The same preliminary analysis showed promising results of a positive predictive value of EEG sleep spindles, although the low heterogeneity of studies. Actually, each individual technique has limitations, and integration of multiple techniques, including multimodal neurophysiology and, when possible, if possible, functional imaging, could have the potential to improve predictive accuracy for the disorder of consciousness, as you can see in this recent meta-analysis. In conclusion, what do we know about the clinical evolution? We know that patients in vegetative state with non-traumatic etiology have a worse outcome than patients in MCS with traumatic etiology in terms of survival and clinical improvement. We know that late recovery consciousness is possible in all diagnostic and etiological groups, although recovery of consciousness does not parallel functional recovery. And we know that medical complication treatment, especially rehabilitation treatment, strongly impact clinical evolution, so the national health systems should implement an appropriate care pathway for these patients. Although prognostic studies show several limitations, we have promising prognostic markers, especially neurophysiological markers such as EEG reactivity, easy to record at bedside and easy to analyze in all patients with disorder consciousness. We know that predictors are different in the two diagnostic groups, and we know that only combined multimodal evaluation could provide robust prognostic information for helping clinicians and patients' family in challenging decision making. Thank you for your attention. I am happy to answer your question. Thank you.
Hello and welcome to World Coma Day, Topic 5, Talk 3, entitled Hope for the Future, Genomics and Biomarkers of Recovery in Disorders of Consciousness. I'm Sheila Alexander. I'm an Associate Professor of Nursing with a secondary appointment in Critical Care Medicine at the University of Pittsburgh in Pittsburgh, Pennsylvania, in the United States of America. I do have a few disclosures. I have received research grant funding to support some of the work I'll be presenting today from the National Institute of Nursing Research and the National Institute of Aging, both part of the National Institutes of Health in the United States of America. I also received some funding from the Society of Critical Care Medicine. I have no other financial relationships to disclose. So I wanted to just give us all a definition, the definition of a biomarker that I use. A biomarker is a defined characteristic that is measured as an indicator of normal biologic processes, pathogenic processes, or responses to an exposure or intervention. Most of the work that I do looks at biomarkers as indicators of pathogenic processes. So when I was first thought about giving this talk, I thought it's going to be very short because there are no known blood or tissue-based biomarkers of disorders of consciousness at this time. I've chosen to present some of my work that highlights the more promising biomarkers, things that aren't quite ready yet for clinical use to tell us who will develop a coma or have good recovery, but things that in the future, with more work and more research, may turn out to be actual biomarkers. So I sort of can categorize these into common pathways of recovery. And the first pathway I'll talk about is some inflammatory pathway. For this first study, I looked at inflammatory markers in a population of intensive care unit patients who do and do not develop delirium. What we found was that upon admission to the ICU, all patients' inflammatory markers went up. But after the day or a day and a half, patients who did not develop delirium, their inflammatory markers dropped. However, for those who either developed delirium or were in a coma, they had elevated inflammatory 6 and some other inflammatory biomarkers that was sustained over at least the first 5 days after admission to the ICU. So we wanted to look a little further and see also within the inflammatory pathway, if perhaps methylation was driving some of this. When methylation just basically turns off a gene's production, so it turns off the protein production. And what we found was that in patients who develop delirium, which are shown in blue in these columns on the right, they had increased methylation of the interleukin-6 signaling transducer molecule that sort of stayed elevated over at least the first 5 days. We also found that for individuals who had delirium, they had increases in interleukin-17C methylation that rose over time, while those who didn't develop delirium started a little higher methylation of interleukin-17C, but dropped over time. So we did find some interesting results in a few other genes on this very large methylation panel, but I've chosen to sort of focus on these two that are the most exciting for today. I also wanted to talk a little bit about energy failure as a pathway of recovery from brain injuries. For this work, I've looked into the severe traumatic brain injury population, specifically subjects that have a Glasgow Coma score of 8 or less. And this actually was led by the geneticist I work with, Dr. Yvette Conley. The mitochondria genome actually makes proteins that are involved in energy production. So variability or polymorphisms within that genome, we think, might change how energy is made and lead to survival or better or worse long-term recovery, depending on the variant. So for this study, what we found was that for individuals who had a certain variant, this A10398G variant, which isn't all that important, but they seem to have a worse outcome over time, that got a little better, but more slowly than those who had the more common genotype. When we looked further at some of the data that we had, we found 3 genes that variability within these genes actually led to differences in outcomes in women, but not in men. So that kind of just speaks to the complexity of the brain's response. Sometimes a genetic variant that is important for women is not so important for men. And I'm sure the opposite is true as well when we really start looking more into these issues. I also wanted to talk about oxygen delivery to the brain as a pathway of recovery. It's very important. The brain needs oxygen. And for this work, I've actually looked at the subarachnoid hemorrhage population, which is a hemorrhagic stroke subtype. And nitric oxide is a vasodilator. So it's a molecule that relaxes the blood vessels, allowing more blood to get to the brain tissue. The eNOS, or endothelial nitric oxide synthase gene, is one of a few genes that make nitric oxide. And this is the one that is active in the blood vessels near the brain. So that's why we thought we would look at this one. We did find that there are variance in two different places on this eNOS gene was associated with outcome. Specifically, having the variant made you more likely to have a poor outcome compared to just the average or common genotype that we see. We also have looked at endothelin-1 receptor B in this population. Endothelin is a vasoconstrictor that uses receptor B. So this actually binds and then decreases the size of the vessel, letting less blood get through to the brain during recovery when this gene is active. What we found in looking just at acute or short-term outcome at 3 months and the Glasgow outcome score, we did find that there are two genetic variants that seem to contribute or associate with worse outcome, meaning people are more likely to either die or be in a coma after their subarachnoid hemorrhage. So then I did some work looking at haptoglobin. The haptoglobin protein actually is important for managing iron and heme and the response to the brain after subarachnoid hemorrhage and possibly some other injuries to the brain. In our initial work, we found that having the 2 version of this gene was associated with worse outcomes. We then contributed data to this large consortium where they did this analysis of about 10 studies from around the world, patients and data from 10 different studies, initially did not find a difference. But what you see is these little, when the circles on the bars shifts to the right, that is a protective effect. It suggests that maybe a certain genotype is associated with worse outcomes after subarachnoid hemorrhage. So we found this in certain populations around the world, but not in others. And we think this may just be to the variability in different races from around the world and that variable response to stroke. Then I wanted to also talk a little bit about some biomarkers of neuronal survival. Apolipoprotein E is a gene that has been implicated in the brain recovery or development for a lot of diseases. Having the 4 version of the APOE gene seems to be associated with worse outcomes. And when we looked in our delirium population, we actually found that the 4 allele wasn't all that important. However, when someone had the 4 allele and a 2 allele in their genetic makeup, as you can see in the reddish orange portion of this column, those patients were in the coma group, all of them. So that seemed like it may be an important feature. And it may be the 2 allele or lack of 3, the more common type of APOE gene. In the subarachnoid hemorrhage population, we found from my initial work that there was sort of a borderline. It may or may not be important. However, in contributing again to a group looking at a large number of subjects from multiple studies around the world, we did find that not having the 4 allele or 4 version of the APOE gene was associated with a better outcome after subarachnoid hemorrhage. So this really just speaks to the power of having larger samples and controlling that variability we see in populations. We've also looked at traumatic brain injury and apolipoprotein E genotype. And while our work did not find a difference, well, that's not really wholly true, but we did find people with the 4 allele more likely to die or wind up in a coma. We found it slowed the progression to full recovery over time. And then that has also contributed to more work, and there's a larger body of evidence looking at APOE and the 4 allele and traumatic brain injury across the spectrum. And what you see here is it appears that that 4 version of the gene it does contribute to poor outcomes in severe traumatic brain injury, as well as moderate, but probably not in the mild. And then if we look at panel B in the lower left, it does seem to be contributing to the progression to dementia in this population as well. So that's the science that I really wanted to talk about today. I think when we look at this body of work, mine, but also the entire scientific community, there's a lot of challenges. Sample sizes are fairly small. You know, we have the facility where I work, we recruit a lot of patients into these groups, but it's still much too small to really address the questions fully with all the other biologic things that may be happening. This is exacerbated by heterogeneity in the samples, people looking who come from different racial backgrounds, of different sexes, of different ethnicities, with different lifestyles and diets. And that external differences are just the tip of the iceberg. On the inside, our biologic responses are also very different and heterogeneous, but depending on genetic makeup and probably other things as well. And it's hard to control for those without large samples. One of the other challenges has been inconsistency in outcome definitions. I tend to use the Glasgow the Glasgow outcome score and the modified Rankin score for the subarachnoid hemorrhage population. But as you've seen, we also looked at disability rating score for the traumatic brain injury population. So there's a lot of different outcome measures we use, and it's very hard to compare them, the results of studies with different outcome measures. However, hope is not lost. I think in trying to address these challenges that I've outlined here, having consistency in our definitions of outcomes and other variables is important, but also collaborating so that we can all contribute data to a much larger group and then truly address the questions that with larger sample sizes that can better handle that individual heterogeneity of samples that we see and just the heterogeneity of being humans. I did want to just point out a few groups that are trying to do some of this work. The Neurocritical Care Society, Neurocritical Care Research Network is doing a lot of work, not necessarily with blood or tissue-based biomarkers, but just around the world trying to do research that is applicable to coma and disorders of consciousness from around the world. HATCH is an international group of investigators that this is the group that actually looked at haptoglobin after subarachnoid hemorrhage. They primarily look at or are trying to enroll sites that have a number of hemorrhagic stroke patients so they can really look at how hemoglobin is managed and how that impacts outcomes, including coma. And then TRACK TBI is a large network of sites that are looking at the best ways to improve care for patients with traumatic brain injury. And I believe they are collecting some genetic markers. So with that, I'd just like to say thank you for your time and for listening to me. I hope it was what you were looking for. And thank you to the organizers for including me in your program. I am so honored and pleased to have been here today. So please enjoy the rest of World Coma Day. Thank you.